Hello, and thank you for joining us for the virtual Healthy Minds, Healthy Bodies seminar, Understand Your Treatment Options for Enlarged Prostate. Today's presenter is Dr. Laciak with Samaritan Urology. Assisting with questions is physician assistant Jordan Johnson. It is now my pleasure to turn this over to Dr. Laciak. Thank you.
Thanks everyone for joining us. Going over today's agenda, we're going to talk about what BPH, or benign prostatic hypertrophy, is, how it's diagnosed, as well as the treatment options, focused mostly on the minimally invasive treatment options that we now have available to us, and also some additions that we're going to have to our office treatment options here at Samaritan. So if you joined my previous talk last year, I'm going to go over a few of the fundamentals of the prostate, a little bit of the history of what your prostate does and BPH before going into the treatment options. So the overview of the prostate: it's a walnut-sized gland at the base of the bladder. It surrounds the urethra, and it produces fluid that transports sperm during ejaculation. So it's important in reproduction, but as we get older, it becomes enlarged and problematic. So it grows to your normal size in your teenage years, and then it starts to grow again after the age of 50. And this is where men start to have their issues with their prostate, typically. Some of the prostate conditions that you may hear about through your primary care or that you may experience are prostatitis, which is a swelling or an inflammation of the prostate cancer, which is a very common cancer among men. It's typically slow growing, and then an enlarged prostate, which is the focus of the talk today. Each condition affects the prostate differently, and having one condition doesn't mean you'll have one of the other conditions. So as we age, the prostate becomes more of an issue because of the growth. I like to talk to my patients that the prostate grows like your hair and nails. It just keeps growing after it starts this regrowth period. So at about age 50, about 40% of men will have BPH or enlarged prostate problems. At around 60, that number jumps up to about 70%. And then when you make it to 80 and above, about 90%, or almost every man in that age group, will have issues with an enlarged prostate. This affects about 40 million men a year throughout the United States. So what is BPH? Again, benign prostatic hyperplasia or hypertrophy. It's a clinical term for an enlarged prostate. This is not cancer. This is just an enlargement of the prostate because it's just an organ that just keeps growing in size with time. It's not an indication of prostate cancer. PSA or prostate-specific antigen is a measure that we use looking for prostate cancer, and this number rises with both BPH and prostate cancer. The reason being is PSA is prostate-specific antigen. Antigen is just another word for a protein. So it's a protein that's made in the prostate. The bigger a prostate you have, naturally the more of this protein that's going to be made by that organ. So the PSA doesn't always tell us which issue you have. So there's a little bit of investigation that goes along with an elevated PSA as well as urinary symptoms. So normal versus enlarged. So as the prostate enlarges, it puts pressure on the urethra, and this is what causes the urinary problems. So in general, the size of the prostate doesn't necessarily correlate with the severity of the symptoms. And what I mean by that is you can have a very small prostate, but if it's blocking up the channel, and this is the channel we're talking about, then you're going to have prostate issues. You can have a very large prostate, and as long as the channel is open, you're not going to have the prostate symptoms that a guy with a prostate half your size may have. So this picture is a normal prostate. This is the 20 or 30-year-old guy that we used to be when we used to be able to pee over the fences with a nice open urethra. Things you'll notice is this is a normal bladder size with thickness. As the prostate blocks up the channel, the bladder decides to thicken. And the reason it does that is because the bladder is just a muscle, just like the heart, and it starts to grow in size just to be able to actually push the urine past the blockage of the prostate. What happens if we don't treat BPH? So again, normal prostate here with an open channel. As it gets blocked up, you get this thickening of the bladder wall. You get this hypertrophy detrusor muscle. So the muscle gets thicker and is noticeable when you look in the bladder. And eventually this muscle, just like the heart, if your heart is is pushing blood past the blocked vessel. It keeps going until finally you have a heart attack. Same thing happens with this muscle. It keeps going until you first start to have symptoms that we'll talk about. And if those symptoms are left unchecked, some men will have a bladder heart attack. The bladder will just stop working and you get stuck with a catheter. So these are pictures that we have. This is a normal healthy bladder on the left-hand side, nice and smooth. As the bladder worsens, this is the thickening of the bladder. So you see the muscles starting to form here. As it thickens even more, you get thicker muscles and you get these little holes. These are called diverticuli for singular, or diverticulum for plural. So these are outpouchings of the bladder that happen. You may be familiar with diverticulosis in the bowels. That happens a lot in bowels when you're constipated and your bowels have to push against a lot of pressure. The same thing happens in the bladder. You get these outpouchings of the bladder wall. This doesn't go away. You can treat the symptoms and you can get better, but when you look in here 10, 15 years down the road, you will still see signs of this in someone that's been treated 10 or 15 years ago. So we tried to see if we can get you before you get to this stage. So this is a few more pictures of the natural disease progression of BPH. Nice open prostate here in a young guy, nice channel, you can pee right through here. As the prostate enlarges, you see the sides coming in and they start to block off. And then this is the significant obstruction. These two sides are sort of crammed up against each other. You can't see past there. Your urine has to push and spread and push these two prostate lobes apart just to be able to urinate. So what are the symptoms of BPH? So this is your frequent urination, your multiple trips to the bathroom at night, this sudden urge, you gotta go now type of feeling that you didn't have when you were younger. Sometimes when you get up at night, you're there for 5 minutes before you even start a stream. That wasn't the case before. So it's that difficulty in initiating urination. The stream can be weak or slow. You used to be able to shoot it past the fence and now you could barely make it past your shoes. Sometimes you even have to sit down because you can't stand at a urinal because it doesn't make it there. This feeling of incomplete emptying and the starting and stopping. So the guys that this affects, you avoid travel. You avoid the things, you don't play the round of golf anymore because you have to hit the bathroom 5 or 6 times during that round. You're using the bathroom stalls because you can't stand and pee anymore, and you're getting up multiple times a night. About half the men in the US with BPH, the symptoms get severe enough and they come in and seek treatment. We're trying to get more guys to not wait until it gets severe enough. You don't want to wait until you have the heart attack to go see that cardiologist. You want to see them when you have the chest pain. And that's what we're trying to get across to a lot of our patients is you're having your bladder chest pain, you're having that frequency and urgency, and maybe get evaluated before things are bad and you end up with a catheter, because sometimes when we wait that long, we can't fix the problem as well because we've waited too long. So how do we diagnose the enlarged prostate? Well, we take your medical history, we do a physical exam, we do a bladder scan often just to make sure that you're not already in retention. Sometimes we have guys come in here with symptoms that have started over the last few years and we find out that they're actively in retention and they actually have to get a catheter because they're already in bad shape from just a few years. We may do a digital rectal exam during that initial visit or a subsequent one, just checking the approximate prostate size and the texture and symmetry. We're going to do an international prostate symptom score, which I'll talk about in a moment, to sort of grade your symptoms and figure out how much this is actually bothering you. So the International Prostate Symptom Score, or IPSS score, looks at all the symptoms we talked about before and it grades your symptoms. So we add up the numbers and we look at, do you have mild symptoms, which is 0 through 7 on the scoring system? Do you have moderate symptoms at 8 to 19? Or are your symptoms pretty severe at 20 and above? And also how this affects your quality of life. We use this score after treatments, via medication or surgical treatments, to sort of see how those treatments are doing. We like to see, when guys are coming in with these moderate or severe symptoms, we like to get them down to that mild or low moderate stage and really improve their quality of life. You may not be able to see it, but this is the symptom score. This is pretty standard for all my new patients that men over the age of 50. Even if they're coming in for something else, I have them fill this out because they may have some underlying urinary problems, even if they're coming in to see me for their kidney stone. So simple form, we add up all the numbers and find out sort of how well or not well you're urinating. The additional studies that we will perform in our office typically is a uroflow and a post-void residual. This is done on a follow-up visit with our medical assistants. You simply come in with a full bladder and you pee into our fancy toilet, so we can actually measure out how strong of a flow rate you have just coming, off the street, how you normally do at home. A cystoscopy. This is looking in the bladder. Those pictures of inside the bladder are all done with a cystoscopy. This is done in our office through a scope through the urethra to get an idea of how much the prostate is blocking up, what the bladder looks like, and also just to make sure to rule out any other things that could be causing some of these issues. Once or twice a year, I may find a small bladder tumor in your bladder looking in here for some urinary issues. Transurethral ultrasound, this is the size measurement. With or without a biopsy, that's if you had an elevated PSA, that's the screening test for prostate cancer. If the numbers are normal, we do a transurethral ultrasound to measure out the size of your prostates, because certain treatment options depend on the size of your prostates. The minimally invasive ones are geared more towards the smaller prostates than the larger ones. And then pressure flow studies, this is urodynamics. This is done in our patients that have maybe either had previous treatments that have not worked, or maybe suffering from some neurological issues, strokes, heart attacks, strokes or MS, something that might be affecting their urination, and maybe it's not just an enlarged prostate causing the issues. So this is what we typically see on a cystoscopy. These are the left and the right sides of the prostate. We use the anatomical left and right. So here you can see this prostate they're really smushed up next to against each other. This one is actually almost indenting the other side up top here. And so this is what you have to urinate past. You have to push these apart to be able to get the urine past. This is a picture of a median lobe. So this bottom part of the prostate can actually grow and actually form another lobe called the median lobe. This is important to sort of figure out at the time of cystoscopy, because it may dictate what type of treatment you're best suited for. This is again a picture of one of my patients with cystoscopy. If you remember from those earlier pictures, the trabeculations, the ridges from the enlargement of the bladder, these are significant ridges, and these are the holes, the diverticulum that I spoke about. So now we're going to get to the treatment options of an enlarged prostate. We'll go through these pretty quickly to get to our main talking points, and then have enough time for our questions. So watchful waiting. This is not doing anything about it, realizing you've got symptoms and saying, well, let's just see how it goes. So the advantages are there's no surgery, there's no medications. It's obviously cheaper than taking any drugs, because you're not doing anything about it, and there's no side effects. The problem is likely the symptoms are not going to improve on their own. Now, if you had something temporary like that prostatitis, that inflammation, that can improve potentially. But if this is simply from an enlarged prostate, it doesn't necessarily then start to shrink. It doesn't go the other direction. So the symptoms will likely worsen with time. Medications or herbal remedies. The medications we've got two different types, the alpha blockers and the 5-alpha reductase inhibitors. Advantages, again, no surgery, and they can provide symptom relief. The disadvantage of the medication is they do have to be taken daily. You're pretty much stuck with these medications until you decide to do something else, or they stop working. The alpha blockers, those are the Flomaxes that you may see commercials for. They can have about a 20% chance of retrograde ejaculation. That's when we ejaculate as men. It goes out our penis typically, and retrograde, it actually goes back in our bladder. There's nothing dangerous about it, but you just won't have anything that comes out of you at the time of orgasm. And you just pee it out later. Some lightheadedness and dizziness also with those. And with our other set of medications, there is about a 20% chance of some erectile dysfunction, side effects, or decreased sex drive, and some very small percent chance of breast tenderness or enlargement. And then the biggest disadvantage is eventually your prostate keeps growing and may outgrow these medications, where the only other option is surgery. Herbal remedies. This is the saw palmetto, and there's a whole bunch of other things you can see if you're up at 2 o'clock in the morning checking infomercials. Most of them have not been studied, so we really don't know if they work or not, and also potential side effects that they have. Saw palmetto is the only one that really has been out there, and it doesn't hurt you. It has helped some patients, so there's not necessarily a bad negative to that one. But again, usually not enough to actually fix the problem. Surgery. So surgery's been, the staple of treatment for BPH for, many decades. So you have the resection of the prostate, which is the transurethral resection of the prostate, the TURP, or you have laser vaporization using either the green light laser or the Cyber TM laser. Pretty much you vaporize the tissue using some sort of a laser technology. The advantages, this maximizes the flow and the symptom relief. The way I talk to patients about this is if we're trying to get out of a room, we can open up a door. That's sort of the minimally invasive options. We can also open up the door and take down part of the wall. So it makes a big, huge opening. And that's sort of what these surgeries have done in the past. They make the largest opening you sort of can make to let the urine. So typically you'll have a much better flow rate with these surgeries. It removes the prostate tissue and it's durable. Most studies look at 5 years, and that's what all of these that I'm going to be talking about. And at 5 years, the retreatment rate for a resection of the prostate is typically pretty low at about 6%, and for a laser, it's about 5%. Disadvantages: the resection of the prostate, you typically have to stay in the hospital overnight, use general anesthesia or a regional spinal block. The laser, since it uses the wavelength of blood, is typically an outpatient procedure, so you can go home the same day. There is a low but possible risk of erectile dysfunction historically. I haven't had this with my patients because historically we used to go all the way out to the capsule where the erectile nerves were, and that heat from either the cutting or the laser could cause erectile dysfunction. I haven't seen that in my patients with these surgeries, but there's a small chance of that. Loss of ejaculation. So that retrograde ejaculation I talked about, that was about 20% with Flomax, is about 60 to 90% with these surgeries. I always tell patients there's about a 90% chance you're going to have retrograde ejaculation, and I can't reverse that for you. Again, nothing dangerous. There's just a small percentage of guys that don't like that feeling. 3% chance risk of incontinence in the literature. I haven't gotten the muscle sphincter. I hope I never do, but it's right next to the prostate. So there's always a chance that you cut more of the prostate that you need to close to the sphincter and get into that. And then a 7% risk of strictures. I tell my patients about 5 to 10%. What's a stricture? When you look back at the picture of the prostate, I'm going to go back really quickly here at this picture. And you see, this is not a straight line. So the urethra does curve a little bit, and right here it really curves. So, you can straighten up the penis right here. You lift up the penis and you put this metal tube in there. Well, the metal tube straightens up all of this, and you can get a narrowing of the urethra because of the pressure that tube puts on it. It tends to happen right past the prostate in this area of the urethra, and it creates a narrowing. So you pee better from the surgery, but then you get worsening urination because you cause this stricture or the narrowing that might require dilations, or it might require additional surgery to take out that stricture. That's a real risk, about 5 to 10%, that I just quote my patients because I take that range, but it's about 7% in the literature. So how do they work? About the same. This diagram sort of shows the resection of the prostate, sort of taking out, physically cutting out the prostate, uses a half circle, and you just take out the pieces with the resection, or you use a laser to vaporize, and you just make this open channel. This is a before and after picture of one of my patients. So here is the prostate lobes blocking things up. We've seen a few pictures of this beforehand. Well, this is the after picture. This is the midline. I take the picture at the same exact point that I did here, and what you see is you don't see these areas anymore. So these are all gone. This is an open channel. This area back here is the bladder. So the bladder has nothing it has to worry about anymore. So all the urine goes through here. As you can see, it makes a big channel opening and should get you a better stream and help with all your symptoms. Okay, so that is the more invasive, but we're here to talk about the less invasive options. So we're going to talk about UroLift and the Resume procedure. Both have been around for some time. Resume for about 5 or 6 years. UroLift longer at over 10 years now. So the prostatic urethral lift or the UroLift system. So advantages: this can be done in the office or under IV sedation. Currently, we do our procedures under IV sedation in the operating room. So we use propofol. So I would guess every man on this has already gotten their colonoscopy. I know I have myself, and propofol was wonderful. And it takes about 10-15 minutes typically. You get some IV sedation, you doze off in the operating room, about 10-15 minutes for me to do the procedure. Then you go and you're waking up in the recovery room. It preserves sexual functions. In their studies, no erectile dysfunction or retrograde ejaculation with this procedure. The relief is pretty rapid. Typically, you're back to normal within about 14 days, and typically no catheter, or I may leave a catheter just until the next morning if there's a little bit more bleeding, or I'm concerned about bleeding, sending you to the emergency room. Disadvantages: some discomfort for a week or two, some potential for some blood in the urine, some urgency, dysuria after the procedure. Not approved for all prostate types. It was FDA approved for prostates under 80 cubic centimeters. They bumped it up to about 100 cubic centimeters, but not all prostates do as well with this, and that's why we would do that cystoscopy and that transrectal ultrasound, figure out which is the best for you. Retreatment rate at about 13.6% at 5 years. I tell most patients, I round it up, I say about 15% retreatment rate, which is higher than the TURP and the laser vaporization. In my hands, looking at my patients, I've been doing this for 6+ years now. I do more of these than anybody in the area, and I'm probably closer to about 10%. But point is, I still have, after all of these, I still have 10% of patients that this does not work on, or it's not lasting after a few months, and the symptoms start to come back. So how does it work? So while you're asleep, or soon to be hopefully in the office, we put a much smaller metal scope in than the Resection. We put some pressure on the prostate to push it over to the side. A needle goes out to the outside of your prostate, and the clip gets deployed on the outside. We keep that tension, and then we put the internal clip on, so it pulls the prostate apart, almost like pulling apart a curtain to open up that channel. This is the size of the UroLift clip. I actually have a nice one that I tend to show. I don't know if anybody can see in my office, so you can actually see the actual size of it. So I put about 4 to 6 of these in most patients' prostates to get the result that we need. What to expect during? Again, this could be performed hopefully soon in our office under some nitrous oxide, maybe a prostate block, or under IV sedation with some propofol in the hospital. We introduce the scope, we place the implants, it takes about 10-15 minutes. This is a before picture, and this is sort of an after picture. This is one of their pictures of a prostate. Typically no catheter just overnight. There'll be some blood over the next week or so. Some short-term sort of pelvic pain down in that area. You get back to normal pretty quickly. I tell most of my patients when I tell them about this procedure, you're going to have frequency, urgency, some burning pain. It's going to be pretty miserable for the first few days. So the first 48, 72 hours, you don't like me very much, and you wonder if you should have even had this procedure done. But after about 2 to 3 days, the symptoms are starting to improve, and that happens by the end of the first week. Most of my patients are actually better by 1 week. By 2 weeks, everybody else is, but I'd say about 80% are better by 1 week. You continue to have symptom improvement over that time period. We see you back typically at about 6 weeks, and patients are doing great at that point. If the procedure worked for them, they're doing very well. On occasion, some of them are still, the small percentage need a little longer, and it's closer to about 3 months, but most of my patients are in pretty good improvement with their symptoms at that 6-week mark. So we're going to move on to the steam-based treatments, the Resume procedure. So again, same as the UroLift, this could be done in office or under IV sedation. Currently, we're doing it under IV sedation. I've been doing this since last year. We're going to move this into the office too, which we'll talk about shortly. Again, fewer side effects in surgery. I like to talk about the Resume as sort of a mini TURP or a mini laser because it does remove tissue. It uses steam to actually remove it. It has a low retreatment rate. So In their studies, about 4.4% at about 5 years. Disadvantages, you do have to have a catheter, and you have to have a catheter for a longer period of time than you do for UroLift. So typically about 3 to 5 days. Right now with my surgery schedule that I'm doing, it's about 5 to 6 days with the catheter. Symptom relief. I tell patients you got about 2 to 4 weeks of that frequency, urgency, burning pain that was shorter with the UroLift. And it takes about 4 to 6 weeks until you get that symptom relief. And then this does have a small risk, about 5 to 10% of retrograde ejaculation. So Flomax, 20%. Surgery, 90% with the resection. Resume procedure, 5 to 10% risk. So much smaller, but still there. And then UroLift is at 0%. So retrograde ejaculation is a concern. Even at a small percent, that's a disadvantage of this procedure. So I'm going to see if hopefully this video, it's worked when we tried it out. So we will see if this actually plays for all of us.
Resume uses a fundamentally different way of applying thermal energy to treat lower urinary tract symptoms secondary to BPH. Each 9-second treatment uses 0.42 milliliters of radiofrequency heated sterile water vapor, which rapidly and uniformly disperses through the tissue interstices. The condensation of water vapor releases stored thermal energy. Cell membranes are gently denatured, thereby causing immediate cell death. The vasculature is closed, and there is denervation of the alpha-adrenergic nerves within the treatment zone, providing you with an efficient, uniform, predictable treatment. Over time, this ablated tissue is resorbed by the body's natural healing response, reducing the volume of tissue, allowing the urethra to open, relieving lower urinary tract symptoms.
All right, so that was successful. So what can you expect during this procedure? So that video sort of showed what the procedure is about. You do about 4 to 6 in a typical prostate, or you can do more with the larger prostate. Steam treatments, they all take about 10 seconds. So the whole procedure takes about, again, 10 minutes in either the doctor's office or under IV propofol. The scope's introduced and we do those steam treatments. Because of the way this works with the destruction of tissue, that's why you need to have that catheter for a few more days and why it also takes a little longer for the treatment. But because it does destroy the tissue, this is a sort of a before with the prostate lobes over here, and this is an after. It's a little hard to see, but all this area used to be prostate, and sort of it all opened up with the prostate, and it's gone now. And so that's why the retreatment rates are potentially less than the UroLift, because you're getting rid of tissue. So what to expect afterwards? Again, the catheter for about 3 to 5 days. Some light blood present in the urine. Again, the pelvic pain, the frequency and urgency is longer at 2 to 4 weeks. Symptom improvement at about 4 to 6 weeks. So when we see you back at 6 weeks, most of patients from this procedure are improved already too. And then it can continue to improve with this procedure because, again, you're reabsorbing that tissue over the course of the next 3 months. So what's next for Samaritan with the office? So we are getting our nitrous oxide. It's being delivered. I expect we should be able to do these procedures with the appropriate candidates and the right patients within the next 3 months. We're moving forward to be able to offer this in the office. Currently, like I mentioned, we're doing this under IV propofol. Some patients may still prefer that. Some patients may still need that, depending on the size of their prostate or the complexity that we see during the cystoscopy. But the hope is that we can start working with patients and doing this in the office. The nitrous oxides is patient controlled, so you would actually have the nitrous oxide and be inhaling it and throughout the procedure and titrating it yourself based on your need of it. Quick recovery, about 20 minutes after you're done with the nitrous oxide, you're in good shape and actually can drive yourself home if you need to. So what's next as a patient? So pay attention to your symptoms before your appointment. We'll have you fill out the symptom score. We really want to know what's bothering you, what's the worst thing that's going on, and what do you want to fix the most. Each of these solutions has unique risk, benefits, and some trade-off to recovery. And our plan with you is to work with you to find the right one for you. And I think we are all set for some questions now.
Is that my cue? So Dr. Laciak, several questions have come in. First one, if I have a procedure done, will I still need to take Flomax and finasteride?
That's a great question. So with these procedures, we will typically have you continue to take Flomax and finasteride because they will help a little bit in that recovery process. And so sometimes, depending on talking to the patients, we may have them stop before, but typically it's nice to take these medications in those first few weeks after. But the goal is to get you off of those medications in the long run. So by the time we're seeing you back at that 6-week mark, we'll be talking to you about stopping those medications if we haven't done so already.
Next one. What's your opinion on a person who just started to take tamsulosin or Flomax and they've had a good improvement in symptoms?
So the question about just starting Flomax and having improvement in symptoms. So that's great. It tells us that you really are having probably prostate issues from the blockage. The Flomax relaxes those muscles and opens up the channel. So it is helping with the symptoms. It is still not helping with the blockage. One of the analogies I give in my office is I go back to the heart all the time because the heart and the bladder are very similar. They're both muscles. They both pump fluid out. One is blood, one is urine. When they're both blocked up, you start having symptoms. One is chest pain. The other is a litany, frequency, urgency, all of those things that we talked about during this presentation. That patient with the heart blockage, if they have some high blood pressure, that puts even more strain on their heart, maybe making that chest pain worse. If their doctor gives them blood pressure medication, brings down the blood pressure and says, well, your blood pressure is down and the chest pain goes away or improves, and they find out that patient still has blockage out of their heart, 9 times out of 10, you're going to go to a cardiologist because when you hear blockage out of your heart, you think heart attack is going to happen eventually for you. That's the same thing we're sort of sometimes finding out with these medications. Your symptoms are better, but the bladder still behind the scenes is still working harder. If you can think about it, when you got your frequency and urgency of urination, you probably had the weaker stream for several years beforehand. Your bladder's been working behind the scenes and you just dealt with this weaker stream. Then it got so bad, you got frequency and urgency. Now you take the medication, you back yourself up a little bit to say, well, okay, my frequency and urgency aren't as bad, but guess what? Now your bladder is still back to where it was before with the weaker stream. Maybe it's gotten a little bit better, but it's still working harder. And that can, end up being causing some problems in the future. So some patients, are okay with the medication, and I say, well, if you just want the medication, that's fine. But I just like to inform you saying, okay, there could be still blockage going on. It's nice to sometimes, call the plumber in and just fix the blockage instead of pouring the little Drano through and having an open pipe for a little while.
Next question. What if I'm on an anticoagulant like warfarin or Eliquis?
So question was, if you're anticoagulated, oftentimes we're able to check with your primary care doctor about stopping the Eliquis or the warfarin. I have patients like this all the time. Probably half my patients are on some sort of blood thinner nowadays because of heart issues, because of blockage, and they're able to stop their medication temporarily beforehand. These patients sometimes have a little bit more bleeding afterwards, and we counsel them that they may be bleeding a little bit more. They're going to be the ones that I do leave a catheter in after a urolift for the next day, just because of the previous anticoagulation. Some of the surgeries, the laser vaporization with the green light, if someone cannot come off because of a recent stent, maybe they can't come off of their blood thinner, you couldn't do the minimally invasive urolift or the resume right now, but if someone was in really bad shape, they couldn't pee, they're in retention, you could do the laser while someone's anticoagulated to get a catheter out of them if you had to. So we have multiple options based on that.
Next one, if I want to come talk to you about this, do I have to have a referral? What if I have Samaritan health plan? Do I still need a referral?
So question about the referral. Generally, we like referrals because it's nice when patients do have primary care doctors, especially after the age of 50, because a whole bunch of other medical conditions come up. However, you can contact our office, reference this this particular talk to the front desk, and they will send the appropriate messages back so we can start getting you all worked in. So that won't cause an issue. Now, certain insurances like the VA system, they do need to authorize some things, but for Samaritan Health and a multitude of other insurances, you can just call us and say that you attended this webinar and you'd like to come in and talk about treatment options. All right.
Last question here. What are the side effects of steam-based therapy? Does this end sexual function altogether?
So question was, does steam-based therapy end sexual function? What are the side effects? So minimal side effects, bleeding, chance of a urinary tract infection are about the most major ones. Again, these can be done in the office. So these minimally invasive ones tend to have very low side effects. It does have a 5 to 10% chance of that retrograde ejaculation. This should not affect your erections. So two different things. You'll be able to get erections with any of these minimally invasive procedures. The steam procedure does have a 5 to 10% chance of the retrograde ejaculation. And that feeling that guys don't like is they can get their erections, they can have their orgasm, but the feeling right at the time of orgasm may feel differently. And this is a very small subset of men. There's a lot of men that get retrograde ejaculation either from having tried Flomax, having had the more invasive surgeries, the TURPs and the green lights, or the resumes that do just fine. But there's a very small percentage of guys that just don't like that feeling. It feels strained. They've described it to me as it just feels weird. That's a very small percentage of guys that do experience retrograde ejaculation have that weird feeling.
Do you do any procedures in Newport?
So the question is, do I do procedures in Newport? I do all of these procedures in Newport. So any of these can be done in Newport. The minimally invasive ones, I do them all the time out there. I do the TURPs, I do the green lights. And so all of these, everything can be done in Newport. The evaluation, because it's a smaller office space out there and we don't have our transrectal ultrasound, we do have to do that downstairs and in the operative suite. You can stay awake for it, but we have some options down there to do it downstairs and keep everything in Newport if you'd like.
After the resume procedure, do you expect an improvement in the flow rate?
So with both the UroLift and the resume procedures, you should have an improvement in the flow rate. After doing the UroLift for 6+ years, I have some guys that really improve their flow rate, other guys that not noticeable, but their symptoms improve. So their frequency, their urgency, they're getting up at night, everything improved. And if we check out a flow rate, we don't see as much of an improvement with their flow rate. The same should happen with the resume though. As you sort of get rid of tissue, you should see an improvement. And we've seen in a lot of our guys that improvement in their flow rate after the resume procedure, but there is going to be a portion of guys that everything else improves except the flow rate not as much as it would for something like a resection of the prostate or the green light. Again, because you're just not making as big of a channel. You're making a channel, so the bladder doesn't have to work as hard. It does not have that blockage anymore. It just doesn't have a big opening to really get that big flow rate going. All right. I think
One last question.
Sorry, we got one more question.
So if you have an enlarged prostate and you have to have surgery for another reason, let's say your gallbladder out, a car accident, something like that, and they have to put a catheter in there, is it possible to cause damage with that catheter, and how long am I likely to need that?
So the question is, if you needed a catheter because of another surgery you had, a gallbladder or an accident, typically those catheters only stay for short periods of time, either right after surgery or they come out the next day. However, we get a lot of referrals because men come in and they get a catheter and then they find out that they can't pee afterwards because of the everything that's sort of gone on. It's nothing that happened because they put a catheter in. It's just because your body has been stressed out by another surgery, an anesthetic, the car accident. Now it sort of pushed you over the edge. So your prostate probably was blocking things up, or certainly was before, and whatever situation you were brought into stressed your body, and now you just can't get that urine out. It was sort of the straw that broke the camel's back type of analogy. It was just enough to put you over, and we will get those referrals after surgeries to get catheters out and start going down through this process. But the catheter should not cause any type of permanent damage. We use them all the time in urology, so but it just may be necessary for that surgery.
Great, thank you so much. Thank you, Dr. Laciak, and thank you, Jordan, for assisting with those questions as well. And to everybody who joined us today, your feedback is extremely valuable. I have placed the survey link in the chat area for you to take a look at and briefly complete that survey. And please watch for the follow-up email that will include the link to the recording today. It will also be posted on Samaritan's website, and expect that communication to arrive your inbox in about 7 to 10 days. And thank you again for joining us, and have a fantastic day.
All right. Thank you, everyone.